This is an area, I think, where, at least in the United States, where there is a little bit of division of labor between cardiac surgery and vascular surgery, unlike Asia and some other parts of the world where cardiovascular surgeons do a lot of the total aortic work. I think there's a nice or natural synergy in terms of treatment of this very difficult segment of the aorta. So when we think about thoracic endovascular repair, aortic repair, there is currently an unmet need. As we know, a significant proportion of thoracic aortic pathologies do involve the proximal descending, encroaching upon the arch itself. And current so-called tubular devices do not address this need. And there is a real anatomic need to extend the so-called proximal landing zone beyond zone 1, zone 3, zone 4 areas into zone 2. And oftentimes the existence of zone 1 is only by name only, and in practice the meaningful distance that one is gained in extending into zone 1 is minimal, and oftentimes those pathologies require full extension into zone 0. Like in any endovascular segment, an off-the-shelf solution versus a custom-made solution due to the inherent delays of customization is always desirable. The history of aortic arch devices extend over a decade, and Stephen alluded to some of this. It started with a single branch device, and Cook Medical has been one of the early pioneers in the industry for this, and you could see this is the early version of this with a single branch designed to accommodate one of the brachiocephalic branches. The second kind of entrant into this space is the Terumo arch branch device, once again with a single branch version. But as soon as some of the early experience has gained into this, both of these manufacturers quickly progressed into multi-branch devices as the need arose. Other single-branch devices have also been shown in the previous presentation. This is a branch version by the Gore, and approximately 50 of these implants have been performed worldwide, including the early feasibility study, and the Medtronic device, which initially had a very small experience, but due to the perioperative complications have largely been placed on hold in terms of further use. The latest entrant is by the Nexus Endospan, and this is what I call a so-called reverse Truder design. Many of you may be familiar with Tim Truder's original version of his arch device, where the actual long portion of the device actually went into the ascending component and the modular component fit into the descending. This is kind of a reverse image where the long segment goes into the descending and the second modular component to ascending, and we're all eagerly awaiting to see the collective experience. I believe as of this date, about 25 implants have been performed of this, and you saw a video from Stephen's presentation, so I'm not going to go into it. So what about these devices? Well, it certainly has enabled zone 0 deployment of the endograft to accommodate the arch branches, as well as create a better landing zone compared to simple tubular devices. But clearly a single branch construct requires longer procedure times because of the need for extra anatomic bypasses, greater surgical mobility, and single vessel dependence on the entire brachiocephalic circulation, which has its downsides, obviously. So therefore, there is an introduction of the so-called dual branch configurations. Again, you saw this. This is the Cook version to accommodate the innominate and left common carotid arteries, with an optional left carotid subclavian bypass based on the actual clinical circumstances. But I think most people will agree that this is beneficial to do this, and oftentimes this is performed as a stage procedure, and I completely agree with this. And you can see the luminal aspect of this, two offset internal branches. The